Let me ask, do you all right, looks like we're getting some responses now, so just click on there. We'd like to know who's with us today. We've got our community-based advocates and systems-based advocates. We have any medical professionals with us or law enforcement. If you happen to be other, please click other and then just type into the chat box who you are so that we know, or like what your role is, so we know that as well. We'll give you just a few more seconds to do that. All right, and it looks like today we have with us pretty much everyone are advocates. The biggest majority are community-based advocates, with just a little under 10% being systems-based advocates. So thank you all for sharing that and being with us today.
Yay, advocates. Awesome. Welcome. Thank you so much. I'm not sure why my PowerPoint just did that, but here we go. So excellent. So we'll tailor the conversation to you and to your needs. We'll talk a little bit about the licensee's obligations to report, so that you have a clear understanding of that, and so that you can do technical assistance in your own communities for your medical personnel. But certainly feel free to ask us any questions that you may have. And so for those of you that have been advocates with us for a while, or that were around this last legislative session, a lot of this might sound familiar, but we want to give everyone a really solid framework so that you can talk about this new law with colleagues in your community. And so we're going to start with a current event to give everyone a big why in terms of why we need this law. It has been a crazy news cycle. We've had hurricanes, we've had the DACA rescission, we've had information go out about Title IX and the loss of protection for sex assault survivors. And so you might have missed this headline. And the headline that was featured in Dallas was 8 dead, 1 wounded in shooting at Plano, Texas home, gunman killed by police. And so as advocates, when we see folks that are murdered in their home, we might simply think that this is a domestic violence case, right? But I have to admit, when I first saw this headline and realized that this was at a football party, I just figured this was a bet gone bad. This was something to do with the drugs or gang violence or something like that. And then the news today, sadly, we find out that this is a domestic violence incident. And so we know now that Meredith Lane was 27 years old, and she really liked to cook. And she had some friends over to watch the football game, and this was her first time that she had had friends over to her house after she had kind of reclaimed the space, and she had asked her husband to leave the house and started a divorce proceeding. And so I imagine she, cleaned the house that day, that she, was cooking and getting ready for this party, and then we find out that her estranged husband at that point came over that night. They fought for about 20 minutes, and then he shot everyone in the house, and he was shot by the police trying to intervene. And so, we know as advocates that this is sometimes the reality of post-separation domestic violence. We know that there are correlations between certainly mass shootings and domestic violence, but that a one-size-fits-all approach or just telling someone to leave isn't necessarily going to solve or stop the violence in the relationship. Here's another example of post-separation violence, or the threat of that we heard during the session. So I was punched in the mouth, fell, hurt my knee, ankle, and had chipped my tooth. I knew that I needed medical services right away, but I was in fear of the medical professionals contacting the police, right? And she went on to say a little bit about her circumstances, and she knew that if it was reported, I would have to fear for my life. And she was told over and over by her abuser that if she ever reported her abuse and he went to jail, he would get out and kill me and anyone who was with me. And this very fierce advocate went on to say in the course of testimony that she was always with her daughter, and that he made no bones about he would not hesitate to kill both her and her daughter. And so she knew she didn't have the opportunity to go to law enforcement to report this. She also added during her testimony that she was actually working as a victims advocate, as a volunteer for a local police department. So this is someone that knew the resources available to her. She knew what the system could and could not do to protect her in terms of protection orders or response to this, and she felt like she didn't have the option to seek health care because it would have pushed her into a response that she didn't feel like was a safe response for her family. And so about 10 years ago, CCADV started to look at the law in Colorado and started to look at the unintended consequences that the law was creating. And the previous law talked about if a physician or licensee saw injuries related to domestic violence, they were required to call law enforcement and to notify law enforcement. And while that is absolutely well-intentioned, we found time and time again that people were so afraid of that they did not seek medical care, or because they simply weren't ready to make that choice for themselves and their families to start a law enforcement response. And we know that the most trauma-informed thing that we can do for survivors is to give them choices, and to give them choices about what happens next for themselves and their family. And so with this, we recognized the intent of the law that had been in effect in Colorado was to get somebody immediate access to services. It was to say that, the healthcare provider was not going to, whitewash this or try to, not know what to do. They would have some sort of course of action that they could take to get somebody immediate help. And so we were able to write House Bill 1322 and to be able to still get somebody immediate help, but for that person to have a choice between a law enforcement response or a confidential advocacy-based response, okay? So again, we want to really just make sure that everyone has a good framework in terms of how to talk about this in their communities. It also came out that during session, we had a physician with our family law partners, our family physicians, and she had been working in the emergency room, and an undocumented woman had come in and started talking to her, and she said, "Stop!" And this was at the time when the deportation order had been enacted, and people were being deported, as they still are. People are not always safe to come to our courtrooms right now and to participate in that law enforcement response. And so the doctor recognized this, that if I had to call police, this could force her and her family into an action that they had no control over. And so she actually, used that to kind of solidify her own resolve or support for this bill, and recognized that we also had to speak for undocumented persons, that they absolutely needed to be safe going to seek medical care no matter what, right? So, and we just got a signal saying we're experiencing technical difficulties, and the webinar will end in 5 minutes. So if you're still with us, could you raise your hand? This just popped on my screen. I do apologize. And it went away. Okay, so I'm assuming everybody's with us. Okay, so 10 years ago, we published a white paper. We started looking at this, and we certainly got to work after everything happened within the last year. So let's come back a little bit to leaving, because we know that post-separation violence is a reality for a lot of folks. And so it helps to talk about this bill in particular when you get pushback, as this was something to help survivors navigate that post-separation violence, right? And so we never know if the law enforcement report or if the criminal protection order is going to be enough to stop the violence in the relationship, right? And so it is a great tool. It is a great timeout. And it can be very effective for a lot of perpetrators. A lot of perpetrators just view the protection order and that whole process as a piece of paper, and we can't guarantee anyone's safety, right? And so we know that leaving is the most dangerous time. We know that when somebody is pregnant and needing to access health care while pregnant, that they need to be able to have honest conversations with their doctors. We know that leaving is a first step, and it is very much a process, and that it can take some time, right? And so it takes time for people to gather up resources and documents and make plans to make sure the kids don't get abducted, to you know, all of the things that go into where am I going to live and how am I going to support myself financially. A lot of folks need to be able to answer those questions for themselves before they make that leap at leaving and staying gone. We also know through the research, and this is well documented, this is the work of Jackie Campbell, that legal separations, like a protection order, plus physical separation from the batterer, that is the point where the lethality is the highest, right? And so knowing all of this, we certainly do not want to block people from getting health care or being able to talk to their doctors about this, so that we want people to be able to speak to their doctors and to be able to certainly make decisions about what comes next for them and if leaving is the right timing for them and all of that. So hopefully that gives you some context in terms of how to talk about this bill as a post-separation violence initiative, okay? So the goals for this bill is, we heard time and time again that, you know, and under the statute, our medical licensees did not have discretion. It was, you shall call law enforcement. And so we had heard stories of survivors going to their doctors and saying, you don't understand, if you call, you're putting me in more danger. And we had some doctors that would believe their survivors and then were jeopardizing their medical license for doing that. And we had a lot of doctors across the state that did not know anything about this law and were not doing it. So we really had some unequal implementation. And so when we started doing the stakeholder meetings and process, we recognized the need that there needed to be some professional discretion for medical licensees. And so with this discretion, it allows that provider to recognize how complicated the lives of survivors can be, right? And so, and it allows medical providers to respect their patients' wishes without having to call law enforcement. So they're not mandated to call law enforcement for domestic violence any longer. So there are certainly circumstances where they are required to call, and we're going to get into that. But after this law is enacted, so after August 9th of this year, they do not have to call them just because someone is experiencing domestic violence. And that, in turn, provides autonomy for survivors, right? So knowing that domestic violence is a patterned crime, knowing that there are probably going to be many times that somebody would need to be able to have these conversations with folks, we wanted to make sure that licensees and medical professionals knew how to handle this and had some guidance from you, the community-based advocates, to address this in their practice, okay? And so this is the big date, and so August 9th, again, if you are 18 years of age and you do not wish to report domestic violence, then that is not the triggering factor for you to have to, for the law enforcement to be called if you seek medical care. So let's go back to, when does somebody report, okay? So certainly there are times when somebody will report, and it is again up to the licensee and their discretion. Nothing about 1322 changes any of the way that child abuse is reported, right? All child abuse is still reported just the same as it was for the last several decades, right? If the patient is 67 years of age or older, elder abuse is certainly an option for that. You are mandated, licensees are mandated to report elder abuse, community-based advocates are not, but domestic violence is not the sole determining factor to determine if somebody is of sound mind and there's not injuries that need to be reported. Domestic violence is not the trigger. If a patient is living with an intellectual or developmental disability, or they are otherwise not legally able to make their own medical decisions, licensees should absolutely report. Okay, and keep in mind too that Colorado is only one of 3 states that did this way. Everybody else had other reporting requirements and were generally under HIPAA in terms of how they reported. But again, we were kind of the outlier on this, which is another precipice for us to change it. So you also report if the patient has experienced an incident of serious bodily injury. So in the PowerPoint that you're going to get a link to, there's going to be a definition of serious bodily injury. Since we have mostly community-based advocates on the phone, I'm not going to go through that definition, but basically your licensee is going to know, or should know, and you can certainly help them with this, when to sign off on serious bodily injury. In terms of if they were willing to sign that piece of paper and they signed this for court, and for systems-based advocates, you know exactly what I'm talking about. They'll sign off that this is a case of serious bodily injury, and that has certainly filing implications for the underlying court case. So if it's SBI, you absolutely report. If a patient has been shot or stabbed, you absolutely report. The shooting or stabbing was already outlined in Colorado law. It's really specific, and the statute actually goes into like ice picks and mechanisms of injury. It also talks about dangerous dog fights, right? And so all of that is still in the statute. The change was we took out the piece about domestic violence in terms of that being the triggering response, and we added and clarified that serious bodily injury is absolutely something that you would call on. Here is a handy-dandy chart of when folks report. This is on our CCADV website, and we built out a section of the CCADV website that is specific to medical mandated reporting, and there you will find guidance for what is a licensee report, what is a nurse report, where are those overlaps. You'll find the link to what HIPAA says about reporting and how you need to have the patient's permission before you report to law enforcement in most cases under HIPAA. And so this is on there, this chart is there, and a lot of other great resources. And so whenever you have questions, you're welcome to go to the website. Certainly when you're out in the community and you're talking to folks and they have questions about what this is, you can use the website as a tool as well. Sex assault reporting options have not really changed, but the intimate partner loophole is closed. And so on this, and again, you're going to get a copy of this presentation, is the link to the updated Forensic Compliance Evaluation Project guidelines. That's a project through the Department of Criminal Justice here in Colorado. And sex assault survivors since 2013, I believe, have had control over how they wanted to report. If you are a sex assault survivor, you get to say, I want to absolutely speak to law enforcement and do a full report. I want to just get medical care and have evidence collected just in case I change my mind. Or you can do anonymous reporting where, medical only reporting is you just make sure you're safe and secure. And then anonymous reporting is when you have evidence collected, you have a full collection kit done, you receive medical treatment, and then that package is tracked by a number through CBI and DCJ, and you have those reporting options as a sex assault survivor. What we were seeing is that sex assault survivors had those reporting options up until the point where they disclosed that the perpetrator was someone they had dated or somebody they were in an intimate relationship with. Then the domestic violence reporting and that mandate kicked in. And so House Bill 1322 closed that loophole. So now if you are a sex assault survivor and you are 18 years of age or older, you have full control over your reporting options, which I think is a really important thing to understand. So when you flip back and you see the medical licensee chart, you'll see that it is fully at the patient's discretion for sex assault and to the licensee's discretion for domestic violence. And let's dig into that a little bit. So in Colorado, we actually list in our state statute who is a medical licensee. And our state statute defines these folks as physicians, physician assistants, anesthesiologists, or an anesthesiologist assistant. Everyone else that is a medical professional is not a licensee in Colorado. There are folks that are operating as a designee of the licensee to perform certain things, right? And so the doctor puts in the orders. It's usually not the doctor doing the blood draw or the catheterization or anything like that. It's usually under the direction of a doctor. So this was not a change under this new law. 1322 did not change the licensee definition. It was in there as terms of licensee reporting, and we kept it that way. What this means for nurses and nurse practitioners is that nurses typically operate as a designee of the doctor, right? And so if your doctor is saying, I'm reporting, or you're reporting, or you're working under their license to facilitate a forensic exam or anything like that, then that is still at the licensee discretion, right? And so you as a nurse can operate as a designee to report, not report, as long as your licensee agrees to it. For nurse practitioners who are under their own license, they are regulated by HIPAA, right? Nurses are regulated under HIPAA, as are doctors. Now, HIPAA has specific carve-outs for domestic violence reporting and reporting other injuries as required by state law. Our state law, under House Bill 1322, no longer requires the blanket reporting of domestic violence. Remember, so it puts that back into the discretion of the licensee. So under HIPAA, you now have to either follow what is in state statute for reporting, and we're going to go through that in terms of how to do all that. So you either follow the state statute or you follow HIPAA. And HIPAA, most of the time, you actually need the victim's permission to disclose this to law enforcement, and you disclose only what you observed, and we're going to go into that. Starting to talk about how this actually looks in practice and how we do this. Again, so licensees have the discretion. If the licensee is not calling law enforcement, if the survivor comes in and says, I don't want this to happen, I'm afraid that if law enforcement comes out, he's going to bond out in less than 24 hours, and then he's going to try to take the kids, or he's going to harm me again, or whatever that is, right? So if they're not calling law enforcement, the licensee, or the designee of the licensee, which I know is a mouthful, to the nurse, typically would write what they observed in terms of what injury the patient had, what demeanor they had, what they heard from the patient, and specifically they would document in the medical file their request to not call law enforcement. The documentation in the medical file is important, and as advocates, you know that sometimes survivors will sometimes file for divorce in custody, or they will file later on, and they say, I never went to the police. I don't have any evidence that any of this ever happened to me. And so by having this documented in the medical file by a neutral third party, those survivors will now actually have evidence of that. So that if it's 5 years down the road and they finally say, I need to get out of here, and they want to file for allocation of parental responsibilities, which requires the judge to make a finding for the best interest of the child, they can do that because they can get their medical records. And this is something that you as community-based advocates can help somebody do. You can help them walk through this process. With electronic medical records, it's not that hard. Epic, which is the big hospital database that is doing all of the electronic records for most of the United States right now, has actually built into their program screening questions for domestic violence. And so this is something that hospital programs are becoming more sophisticated at looking into and working on. And so, again, the timing for this bill, again, allows people to have these conversations with their doctors without having an unintended response. So that's if you're not calling law enforcement. You write down what you know. If you are calling law enforcement, because now we're not just blanket reporting, you are bound by HIPAA as well, right? And so it's only what you observed. And so if you come in, or if you're calling law enforcement and you say, the patient has a laceration on her thigh, that's what I can say. I can't say the patient has a laceration on her thigh and she told me the story about how that happened and that it was domestic violence and that she's really afraid for all of the other things. All of that's a little bit too much under HIPAA. It's really just the identifying information of the patient that you're treating, and HIPAA actually will go through in terms of which personal health information or which PHI you can say and what you observed. You also, as a licensee or a nurse and as a decent human being, need to confidentially tell that survivor that you're going to call law enforcement. And so this does not mean standing in front of the perpetrator as well as the survivor telling them that you're going to call the cops. But this says, hey, so I'm really concerned about your health and your well-being here, and I feel like I need to call law enforcement, right? And so you need to document in your file that you made good faith efforts to confidentially inform the survivor that you were going to call law enforcement. And that's it. You don't have to put anything else in the file, just that's the check mark that I did it, right? And that is what puts you into compliance with the new law 1322. Now, the other piece of this is that whether or not the licensee or the nurse made a report to law enforcement, so if I'm reporting for law enforcement or I'm not reporting to law enforcement, I have to make a referral to a confidential victims advocate, right? So I'm required to say, I'm really concerned, here's some information, can I help you call somebody, right? The medical licensee has no liability attached to the services rendered by the confidential advocate. The best practice that we are training on and that we want you as advocates to be aware of and to train on in your own communities is that the best practice is really to create a safe space within the exam room for the survivor to call the confidential advocacy program, right? For your programs, this looks like any other call that you would get on your hotline. So, right, so under our federal requirements under FIPSA, the Family Violence Services Prevention Act, which most of you in the state receive FIPSA funding for, you're required to have a hotline, right? So you get a call to the hotline saying, you know, my doctor's here, he's making me call, what's going on? And you treat that as an information and referral call, right, in terms of like, I want to make sure that you have information about your options, that you know somebody's here for you, that you have access to resources. You know, for some of our programs, we have advocates that are also the VRA level advocates that are going out to law enforcement calls, and so really no different from you. You would go to the emergency room anyway, or you would go to the help the law enforcement response anyway. So if you can go to the emergency room and provide in-service advocacy, great. You can do that if your program has resources to do that. But realistically, everything has always started over the phone, right? People just don't typically show up to a confidential shelter and knock on the door. It's usually a phone call saying, you know, what services do you provide? So you would talk to them about services you have, make a plan to meet them. Whatever your protocol is, if your plan is to bring somebody into your office or your shelter location and meet with them there, great. If you are safe to meet them somewhere else out in the community or that is part of your regular advocacy practice, great. So the more that you have these relationships with medical providers in your community, the more people I think are going to be able to call the advocate and maybe not feel like they have to call the law enforcement as much, right? And so when you have those relationships where they know that, you know, I know, and I don't even know who's on the phone, folks, but like, say I know that, you know, Jenny in Leadville, her services are awesome. I'm going to call advocates and they're going to take care of it and I'm okay. I feel like they're going to give them the right information. And so cultivating those relationships, letting people know that you're there, letting people know that that's a resource for them is going to be super important to the success of this, but realistically, it's not going to change your day-to-day practice because you're already getting these information referral calls, you're already doing this. And so for sex assault survivors, We do not have the same level of, there's no documentation, separate documentation needed for sex assault survivors under 1322. Again, that's a different process. And this law really only applies to domestic violence survivors, but again, if you are a dual agency program, we also encourage licensees and medical personnel to call a confidential advocacy program for sex assault services as well, because we know confidential advocacy services for sex assault are absolutely necessary and do really well for survivors. Now we have mostly confidential advocates on the phone, so I don't need to harp on this very much, but certainly, you know that not all advocates have the same duties and privilege, right? And so systems-based advocates, your job is to aid in the prosecution and investigation of the criminal case. And so you obviously are required to keep everyone informed of what the victim has said to you and to document that. And you do a great job of that. Community-based advocates do not, under most circumstances, cannot be called to testify. You don't provide any information about client identity, participation in services, facts of the case, anything like that. Mum's the word, all of that stuff. And so I'm not going to go over that, but there is a statutory citation if you haven't looked at it in a while or just want to look at its glory. There it is. So when a doctor or someone is talking to you about, like, well, you know, what do I really have to do under this? And so there is a section of the statute, and again, you're going to get a copy of that when we send you the PowerPoint, that specifically speaks to immunity. And so there is criminal and civil immunity for both options, right? So if I decide I need to call law enforcement because I'm not comfortable with just not doing that, or referring to a community-based advocate, I have civil and criminal immunity. If I, you know, do call, that's fine. HIPAA is going to interact on this if you're not operating as a designee. So if I'm not a physician, physician assistant, anesthetist, or anesthetist assistant, and I'm operating under somebody else's medical license, essentially, right? Or I am working as a designee of one of the licensees. HIPAA decides and dictates a lot of that too, right? So for nurse practitioners who, again, they are completely under their own volition, HIPAA. If you are a nurse and you're acting as a designee, you can absolutely follow what is in House Bill 1322 as the path and the list of steps for you to take to work the situation. Everything in 1322 is fine under HIPAA. The piece that you need to be aware of is that you're good for civil and criminal immunity no matter what, and we talk a lot about good faith efforts in that. HIPAA may have some other consequences in terms of it's usually a fine against the hospital if there's a HIPAA breach. And so if you are calling law enforcement, just make sure that you are aware of what your hospital policy says about HIPAA, and make sure that you're following your hospital policy on top of this. Okay, and certainly we're doing a lot of technical assistance around this question in particular right now, and so feel free to call me with any specific questions you may have. Absolutely, and we have promised that certainly for our members, technical assistance is always free. We usually charge for people that are not members for, excuse me, higher level TA, but it's free and medical mandated. Okay. Excuse me. So your next steps. We want you to consider developing an MOU with your local provider, right? And so go to your local medical providers, and especially for our rural advocates, you know, going to if you still have smaller practices in your area. I know a lot of the practices are being bought by Centura and UC Health and larger folks, but if you still have independent practitioners, going to them with your information and talking with them through this can be very helpful. You can certainly write an MOU. There are sample MOUs available to you. We have resources here, and so if you need help developing an MOU for that, you certainly can. Medical professionals can call hotlines too, right? And so if I'm a medical professional and I see somebody in my practice and I just don't know quite where to go under this law, you can call a hotline. The backup hotline for everything is actually the national hotline as well. And so during these stakeholder meetings and during these conversations, the question was asked, well, what if someone speaks Ethiopian or Urdu or a language that I don't have access to and most of our shelters don't have access to? And so the backup is the national hotline. And so most of our programs, certainly you have your 24/7 crisis hotline. If somebody cannot get through on that for whatever reason, they can call the national hotline. Between the two numbers, something is going to work. You both have really excellent response rates, right? So national response rate is around 88%. Our local programs, I'm sure, are just as high. It's been a while since we've actually done a study on that, but you guys do really well. We know that. So if you need help with other languages or for some reason you can't call the local program, you can call the national hotline, and they can also provide an information referral. And just as an FYI, and community-based advocates know this as well, the national hotline will actually route you to the nearest program. And so a lot of times you'll get through to them and they'll route you through back to the shelter. And so you will have access to local resources. Keeping in mind that the whole premise behind this is that sometimes it takes time and resources to get safe and stay that way, and we certainly don't ever want to hinge our ability or our willingness to help a survivor on their ability or their willingness to leave a situation or do what we think they should do. Again, that survivor-centered advocacy is all about listening to what they need and helping them figure out what their options are and supporting them in those options, right? That there's no one-size-fits-all advocacy that works, and so we have to provide survivors with options and resources, and those might look different from case to case, and so certainly this law allows for that, under allowing for discretion, and again, that immediate access to services, and so I think it's also a helpful way to think about this. And patient disclosures are only one step, right? And so that first disclosure is the long process, and the first time that someone is really going to kind of disclose that can be very emotional and certainly very personal, and so being able to honor that, recognize how hard it is for them to say those words to you, and then to be able to offer them immediate help and not jeopardize their confidentiality or their safety and well-being is really important. And so certainly best practice for our medical folks is to certainly not just have this one-time interaction with folks, but again, usually you have your established physician, if you have healthcare, to be able to have those conversations again and check in with them again, knowing that you have the ability to confidentially and privately communicate with your doctor. And again, research is telling us that confidentiality and privacy are linked more and more to safety, right? And so we have some DVP numbers actually on the side of the page here. And we're going to introduce our final poll now. See who is still awake and with us and not succumbing to the technical difficulties. We count. Yeah. Oh, sorry, two final polls. So we're going to do one and then followed by the other, which is just a real quick survey, and that's going to set us up for messages. And so we certainly want you, again, we want you to type your messages in or raise your hand. We've had some technical difficulties, so I think the chat box is probably the safest way to get your questions today. And we have a poll open, and I'll let Shannon introduce it.
So if you work at a domestic violence agency, you know that the NNEDV census is tomorrow, and you know that your agency is planning to count. So Either yes, you already know that, no, you don't know, or no, you don't plan on counting. So feel free to put your answers in there. Take just a few more seconds. Again, this is in regard to the NNEDV census, which is happening tomorrow. We have about half of you who have participated. We still have some more contributing. And depending on your roles, you might not be aware of this when you're at the agency. Some of you, based on your roles, might be more familiar with this sort of thing, and Lydia will talk just a little bit about that as well, so that we all have a better understanding of why that occurs and why it's important. And it's okay if you don't know.
It is. We will give you a call this afternoon if you don't know.
Let's see here. So it looks like we have a big majority who have voted, and we have 64%, so over 60 and growing, continuing, that number's continuing to grow, that say yes, they will be participating in that tomorrow. We have a real small percentage that says no, and then we have about a 30% who say they don't know.
Awesome. So here's why we had to put this in here today in a policy brown bag. So for those of you who can see the screen right now, you'll see, for those of you policy geeks, you'll recognize those as DVP numbers. And so those are the numbers that the domestic violence program through Colorado Department of Human Services puts out because they're required to under FIPSA. They're the FIPSA administrators, the Family Violence Services and Prevention Act. So numbers for domestic violence are really hard to come by, as are stories about how things are going out in the field. We have the numbers that are collected by FIPSA in terms of how many people are coming into our shelters and how many people are accessing hotlines. But the census gives us a one-day point-in-time study of who's in shelters and what our advocates really do all year, and those numbers are critical, absolutely critical, for us to work on your behalf at the coalition level, whether it be your federal members of Congress telling them about, these funds are critical because we have to do, training, we have to do education, we have to be able to implement the laws we pass and keep the doors open, the lights on, that sort of thing. So we certainly want to get those numbers. If you are not participating in the survey for whatever reason, or if you have questions, go back to your agency today and ask if you're doing it. If you're not doing it, or if you have further questions, please do give myself or Amy Pohl a call this afternoon so we can walk you through it. It is really, really easy to do, I promise. And those numbers really help us understand what's going on in Colorado, so that both with our federal decision makers and our local decision makers, we can give them a story of what's going on in Colorado. We always get a question in terms of, well, what services do you provide, especially in the rural parts of the state? Because there's this perception that somehow our services are not as robust as they need to be in the rural parts of the state. And so while we could always use more resources, I know and we know that especially our rural partners do a very good job and provide robust services in really challenging circumstances. And we need to be able to tell that story, and the census allows us to do that. So please do participate. And then our final poll today, we'll go ahead and launch as we do a quick review. So, at the request of the survivor, licensees can choose, right? They still have immunity either way. Whether or not somebody chooses to report, they need to make that call to that confidential advocate. If the licensee wants to report over the patient's wishes, they need to notify that person that they're going to report before they make the call. And again, this only applies to domestic violence cases, right? There's no documentation requirements like this for sex assault. So we're going to open up the remaining time to the last poll and to your questions that you may have.
So this last poll is now, after hearing the information today, you completely understand how the new law is beneficial for survivors. Lydia gave herself no room here, so it's either yes or no. And certainly if you type no, please take a moment and into the either question box or chat box, feel free to enter your question or any other thoughts or concerns that you might have. We know that some of you may already be working with law enforcement in your area or medical service providers or medical professionals, and maybe have already had questions come up about this, or perhaps some type of pushback or anything like that. So any thoughts that you'd like to share about that or questions that you have around that, we'd love to hear those right now as well. Looks like we have over half of you that have shared so far, and Lydia, you're doing quite well because the majority have all said that yes, they understand how this new law is beneficial to survivors. And we know not only for it being beneficial for survivors, but again, how do you feel comfortable in approaching your medical professionals in your area, working on that MOU with them, and just being able to open up more opportunities for survivors to get connected with community-based advocates. So again, if you have any questions right now, I did notice too that we had a couple people or one person who had raised their hand during the presentation. So if you would like to type your question into the question box, if you still have it, or perhaps you raised it to say, hey, I'm having issues with my screen or something else like that that we've addressed through the chat box, please feel free to do that as well. So we'll give you just a minute or two to type in any questions that you might have. So we're going to go ahead and close the poll. Again, good job, Lydia, because it looks like most everyone totally understands how this is beneficial for survivors and how they plan on working with it as well.
And then also keep in mind that we are always here for technical assistance, especially on this issue. And so if there are questions that you still have that you do not feel comfortable typing into the open chat box, my email address, which I realized I forgot to put on the PowerPoint, but again, we're going to send this out to folks, is just Waligorski at CCADV.org. You do not have to learn to spell it. There is a link right to my email address from the CCADV website. So, oh, thank you, Shannon. So if you can find the website or get it from the chat box now, you certainly can. So we have questions. We built this PowerPoint to be used for a variety of folks. And so if you want to dive into the mechanics of this, there's a link to House Bill 1322 right here built into the PowerPoint, so you can go back for your own knowledge and find that. The serious bodily definition is in here. There's a slide on strangulation, and that is kind of a higher tier understanding of how strangulation interacts with this. If there is serious bodily injury, you call. If it is strangulation but not serious bodily injury, you are not legally required to call. That is a whole webinar that we could do on those intersection of those two that I'm happy to do if there's need or interest for it. But you have some basic information here. There's our beautiful strangulation spelling that we all work so hard for, and that's it. So again, we're here for you. I thank you so much for the work that you do.
And we do have a question, Lydia. So someone asked, do we have a best document that you'd encourage us to use when talking with our local medical personnel?
There were several one-pagers that were created through this process, and so I would encourage you to take a look at the CCADV website and find something that you want to use. And if when you click on it, it's not in a good usable format for you that you want to share, get a hold of me and I'm happy to craft that. So we've got a lot of information. There are a lot of links on that to some one-pagers. So look there, and if you don't find what you're looking for, I'm more than happy to create something.
Okay, great. And let's see here. Yes, so last but not least, again, our sincerest apologies for the technical difficulties we've experienced throughout this. This was recorded, so we will listen to that recording. Hopefully you'll be able to catch some pieces, and hopefully maybe through the recording it came better for some of the pieces that you might have missed. The presentation will be emailed to you. We will send that shortly with the presentation and links of where you can find some of the information that Lydia referred to as well. We will include that also. Last but not least, when you close out of this webinar, a brief survey will come up. There's only 6 questions. I promise it'll take you a minute, if that, to answer those questions, but they really help guide us in providing information for you and what it is that you want to hear in these brown bags. Our next brown bag is next month, Tuesday, October 10th from 12 to 1. So again, we'd love to hear more about what it is that you're looking for and how it is we can provide you with information that you need to continue to be able to do the work that you're doing with survivors. We also want to let you know that next week on Thursday, September 21st from 12 to 1:30 p.m. in cooperation with the VITAL project, we do have a webinar on building an effective board. So this is excellent information for current board members, certainly for any directors or those who work with boards, or anyone who just wants to learn a little bit more. So feel free to reach out if you haven't seen an email about that with the link for that. And then again, we will follow up with an email that will have all the information that you need from today. Feel free, and we'll make sure Lydia's information is in there so you can reach out to her directly with questions about this. You'll have my contact information as well for any questions related to other items that you might need technical assistance for. And we appreciate your time today. Thank you all for the work that you're doing, and we'll talk to you soon.
Thank you.